Check, check. Check one, check two, check, check.
Absolutely. Let's explore venous thromboembolism, or VTL, in even greater detail. We will cover its epidemiology, comprehensive diagnosis and treatment approaches, potential complications, patient management strategies, and current research trends. Incidence and prevalence. VTL is a common condition, with estimates suggesting that approximately 1 in 1,000 adults develop a DVT each year. The overall lifetime risk of developing VTL is about 10% to 30%, depending on risk factors. The incidence of PE is lower than that of DVT, but is a significant cause of morbidity and mortality. Mortality, PE, is a leading cause of cardiovascular-related death. Studies suggest that PE contributes to approximately 10% to 30% of all hospital deaths. Early diagnosis and treatment significantly reduce mortality rates. Venous thromboembolism, risk factors, major risk factors, recent surgery, particularly orthopedic like hip and knee surgeries and major abdominal surgeries. Cancer, certain malignancies, such as pancreatic and lung cancer and chemotherapy, increase VTEL risk. Trauma, especially fractures of the pelvis or lower extremities. Moderate risk factors, hormonal therapy, use of estrogen-containing contraceptives or hormone replacement therapy. Prolonged travel, long-duration flights or car rides can increase risk due to immobility. Minor risk factors, obesity, a body mass index or BMI greater than 30 is associated with increased VTEL risk. Varicose veins, increased risk of developing DVT, family history. A personal or family history of VTEL can increase risk. Advanced diagnostic techniques, D-dimer testing. A negative D-dimer test can help rule out VTL, especially in patients with low clinical suspicion. However, elevated levels can occur in various conditions, including infections and malignancies. Compression ultrasound, the primary imaging method for diagnosing DVT. It assesses the venous system and detects clots by evaluating blood flow and vein compressibility. Sees CT angiography, the first-line imaging modality for suspected PE. It provides detailed images of the pulmonary arteries and can identify occlusions. Magnetic resonance sonography, or MRV, occasionally used, particularly in patients who cannot undergo CT due to contrast allergies or renal impairment. It provides high-resolution images of the venous system. Immediate management of deep vein thrombosis involves anticoagulation. Heparin, particularly unfractionated heparin, is often used in acute settings, especially when rapid anticoagulation is needed. It requires monitoring of activated partial thromboplastin time. Low molecular weight heparins, such as enoxaparin, are favored for their predictable pharmacokinetics and reduced need for monitoring. Management of pulmonary embolism also involves anticoagulation. Immediate anticoagulation is initiated, similar to DVT. If the PE is massive and causes hemodynamic instability, thrombolytic therapy may be warranted. Thrombolytic therapy is administered for high-risk PE cases, particularly in patients with hemodynamic compromise. The risks of bleeding are significant, so careful patient selection is essential. Surgical embolectomy is an option for patients with massive PE who are not candidates for thrombolytics. This is less commonly performed but can be life-saving. Long-term management involves continued anticoagulation. The duration of anticoagulation therapy typically ranges from 3 months to indefinite based on the underlying cause, whether provoked or unprovoked, and patient risk factors. Follow-up and monitoring require regular appointments to assess for recurrence and manage any complications. Patients may undergo repeat imaging to confirm the resolution of DVT. Short-term complications include recurrent VTEL. Patients with a history of VTEL are at increased risk for recurrence, especially if risk factors persist. Hemorrhage is another concern, as intravenous anticoagulation increases bleeding risk, particularly in patients with existing coagulopathies or those undergoing surgery. Long-term complications include post-thrombotic syndrome, a chronic condition following DVT characterized by pain, swelling, and skin changes in the affected limb. PTS affects quality of life and can lead to disability. Chronic thromboembolic pulmonary hypertension is a rare complication of PE, where blood clots lead to persistent high blood pressure in the lungs. It can occur months or years after the initial event and may require surgical intervention. Patient management strategies include lifestyle changes. Encouraging regular physical activity and mobility, especially after surgery or during long periods of immobility such as travel, is essential. Dietary adjustments, like maintaining a healthy weight and diet, can help manage risk factors such as obesity and hyperlipidemia. Education and support are crucial. Informing patients about symptoms of DVT and PE, the importance of medication adherence and lifestyle modifications can reduce the risk of recurrence. Engaging with support groups can help patients cope with the psychological aspects of living with VTL and its consequences. Current research trends include novel anticoagulants. Ongoing studies are exploring the efficacy and safety of new oral anticoagulants such as betrixaban and edoxaban, which may offer advantages over traditional therapies. Genetic studies are being conducted to understand the genetic predispositions to VTEL, including the role of inherited thrombophilias, such as the factor V Leiden mutation. Technology in VTL management is also evolving. The use of machine learning and artificial intelligence to predict VTL risk based on clinical data is an emerging area of research. Enhanced predictive models could lead to more personalized preventive strategies. Primary prevention involves education on risk factors, like raising awareness about modifiable risk factors, such as smoking cessation and weight management. Prophylactic measures in high-risk populations include the use of mechanical prophylaxis, like graduated compression stockings, in patients undergoing major surgery or those with limited mobility. Secondary prevention may involve long-term anticoagulation for patients with a high risk of recurrence. Regular monitoring includes follow-up visits to reassess risk factors and medication adherence. Venous thromboembolism is a complex and significant health issue that requires a multifaceted approach to prevention, diagnosis, and management. Understanding the underlying mechanisms, risk factors, and treatment options is essential for healthcare providers and patients alike. Continuous research efforts aim to improve outcomes and reduce the burden of VTL. If you have more specific questions or areas you would like to explore further, please let me know.